Good afternoon. My name is Dr. Michelle Henry from the University of Cape Town in South Africa. Today I'm speaking to you about sleep and cognition in non-functioning pituitary adenomas. And this was research conducted by myself and my colleague, Dr. Ian Ross, and our master's student we were supervising at the time, Ms. Musadiga Brown. So why did we decide to conduct this research? Existing literature shows that HPA axis hormones are important for sleep regulation and cognition, that sleep is important for overall cognitive functioning, and in particular memory consolidation, and that patients with pituitary disease experience hormonal dysregulation alongside impaired quality of sleep and particular patterns of cognitive dysfunction. At the time of the current study, it was the first to examine whether there are relationships among sleep disruption, cognitive impairment, and the presence of pituitary disease. Pituitary diseases are commonly caused by a tumor in the pituitary gland, and these tumors can be designated as functional or non-functional. Functional tumors secrete hormones in excess, whereas non-functional tumors do not produce excess hormones. Both types of disease, though, can be treated with medication, surgery, or radiation therapy, depending on the tumor's type and size. Although non-functioning pituitary adenomas are hormonally inactive and do not cause direct changes in the secretion of hormones, they can impair hormone production, and consequently, patients with these tumors may require lifelong replacement therapy. Research has shown at the time of diagnosis, 60 to 85% of patients with non-functioning pituitary adenomas present with at least one pituitary hormone deficiency. And non-functioning pituitary adenomas have significant effects on cognitive functioning, partially due to changes in hormone levels, but also due to the pressure they place on the pituitary gland and the surrounding brain structures. Patients also frequently present with short-term memory problems, learning new information, and inhibition, and they're also known to have alterations in their sleep, attributed in part to alterations in hormone levels. So let's look at hormones of the HPA axis and cognitive functioning. So persistent cognitive dysfunction may be due to electrophysiological or neurovascular changes due to the tumor, pressure on the surrounding brain structures, or because patients may suffer from coexistent hormone deficiency or excess. So both hormone and cortisol interact with brain structures and are known to affect cognitive functioning. Growth hormone alterations have been known to influence attention, visuospatial ability, memory, verbal fluency, and executive functioning. The hippocampus, an area in the brain, has high concentrations of mineralocorticoid and glucocorticoid receptors. And such alterations in cortisol have been known to cause impairments in encoding of new information, memory retrieval, and impairments in memory consolidation. Another master's student of ours has conducted a systematic review and meta-analysis of cognition in pituitary disease. This research has shown that cognitive impairment is consistently observed across different pituitary disease subtypes, and that 87.5% of patients still report cognitive impairment despite treatment. The largest impairments we see are in working memory, verbal memory, and processing speed. So now let's talk about sleep. The HPA axis plays an important role in modulating the complex process that determines the need, timing, and organization of sleep. From this diagram that I'm displaying, one can understand why patients with non-functioning pituitary adenomas may have altered sleep due to changes in hormone levels. A few studies have investigated sleep in non-functional pituitary adenomas. They have found that both self-report and objective data confirm alterations in sleep, including changes in sleep architecture, reduced sleep quality, daytime impairment, fatigue, and sleep apnea. So why are we so interested in sleep? Sleep is a normal physiological process that is vitally important for our overall health and well-being. Specifically, sleep plays a crucial role in promoting cognitive functioning, particularly in the domain of memory consolidation. It also plays an important role in emotion regulation, and disrupted sleep has been associated with many psychiatric conditions such as depression, anxiety, post-traumatic stress disorder. And lastly, sleep is also important for our physical health. Sleep is a period that is free from disruption and disorder, and the adequate duration and timing of it is important for our immune system and many other areas of physical health. So the main aim of this study is to examine the relationship between objective sleep and cognitive functioning in patients with non-functioning pituitary adenomas. And as I mentioned at the start of my talk, the reason we are interested in this is because hormones of the HPA axis are important for sleep regulation and cognition. Sleep is important for our overall cognitive functioning, and research has shown that patients with pituitary disease experience hormone dysregulation alongside impaired sleep and cognitive dysfunction. So, hence the aim of the study is to quantitatively test memory in patients with non-functioning pituitary adenomas and compare it to healthy controls, to examine sleep in patients and controls, and to explore the relationship between sleep and memory. Our study set out to test the following hypotheses. Compared to healthy controls, we expect patients will have poorer sleep, they will have more impaired cognitive functioning. Cognitive performance is going to be superior after a period of sleep compared to a period of wake. And I'll discuss this a little bit more when we discuss our study design. And that poor sleep is going to be related to worse cognitive performance. So this study was a quasi-experimental study where we repeatedly tested patients with non-functioning pituitary adenomas and controls across two conditions, a sleep and a wake condition. The dependent variables are cognition, and specifically for the study, we were looking at declarative and procedural memory, and the other dependent variable is sleep, which we measured objectively using actigraphy. We successfully enrolled 10 patients from a clinical database and 10 matched healthy controls. Healthy controls could obviously have no medical or psychiatric conditions, and patients needed to be on stable treatment for the past 6 months. We excluded any individuals with psychiatric conditions, head injuries, stroke, epilepsy, as these are known to impact sleep and cognition. And we also excluded people who were taking medication that is known to affect sleep and cognitive functioning. So let's look at our study design. Patients and controls underwent two conditions, a sleep and a wake condition. All testing took home in participants' home environment to minimize the confounds of studying someone in a laboratory and to provide real-world applicability. Patients and controls took part in, first, a sleep condition, where they learned some materials. Thereafter, they went to sleep as they normally would, and they wore an actigraph so we could objectively measure their sleep. And 12 hours later in the morning, we did a delayed recall. A week later, they took part in the wake condition. This was almost identical to the sleep condition, except the 12-hour period between learning and delayed recall was when they were awake. So they learned their material in the morning, were instructed to stay awake for the whole day and go about their usual day, and in the evening they did the delayed recall. We used alternate versions of each test to avoid practice effect, and conditions were counterbalanced across participants. Now let's look at the results. Our participants were on average 50 years of age, relatively well educated, and the majority female. And as we can see, we successfully matched our patients and controls in terms of these demographic variables. In terms of our patients, all of our patients had some form of endocrine deficiency, and most had at least one comorbid medical condition. All had been treated with surgery and 7 with radiotherapy. Importantly, many patients were taking hydrocortisone, which has important implications for sleep and cognitive functioning. And of note is that none were replaced with growth hormone, despite some being growth hormone deficient. This is because in our setting in South Africa, we were unable to replace patients due to the cost. And let's look at the sleep results. There were no differences in objectively measured sleep. However, patients did self-report worse sleep quality and alertness and mood upon awakening. Just to highlight that actigraphy is a crude measure. It only tells us whether someone is asleep or awake, and this can be misleading because if one moves around a lot at night, the actigraph might indicate that that person is awake when actually they are asleep. Furthermore, actigraphy does not allow us to investigate sleep architecture. So while patients and controls seem to have similar objectively measured sleep by actigraphy, we do not know about the length and sequence of sleep stages, which we know is important for cognitive functioning. In terms of our cognitive results, looking at the declarative memory task, there was a significant main effective group. Controls' performance was better than patients. However, there was no main effect of condition. In other words, it didn't matter whether you were in the sleep or wake condition, you seemed to perform relatively equally well, although both patients and controls performed slightly better in the sleep condition, and there was no significant group times condition interaction. In terms of the procedural memory task, there were no main or interaction effects. However, one can see that the performance was quite a lot better in the sleep condition than in the wake condition. So this study aimed to describe sleep quality, memory, and their relationship in patients with non-functioning pituitary adenomas relative to healthy controls. We found that patients had impaired verbal declarative memory. However, there seemed to be no significant effect on procedural memory, although controls did perform better and performance was better after a period of sleep. There were no significant between-group differences in objectively measured sleep quality. However, subjective sleep quality was poorer in patients, and no correlations were found between sleep and cognition. So future research. We used one test of verbal declarative and procedural memory. Additional or alternative tests may provide us with more nuanced results. We also need to determine what other types of memory may be affected. For example, visuospatial memory, working memory, perspective memory, and other types of cognition, such as executive functioning, which is known to be impacted by hormones of the NFPA axis and sleep. An important future study that needs to occur is a polysomnograph study. Actigraphy is a very crude measure of sleep and tells us nothing about sleep stages. And we know that it is the sequence and timing of sleep stages that is important for successful memory consolidation and effective cognitive functioning. If it is found that patients have altered sleep architecture compared to healthy controls, a sleep intervention may be useful because improvements in sleep may have downstream benefits for cognitive functioning. Lastly, due to our limited sample size, there are several important factors that we could not investigate. We do need a larger sample size to understand the implications of disease characteristics, such as different replacement therapies, treatment duration, and disease duration, and the impact of comorbid conditions which our patient group presented with. Thank you for listening to my talk.